Again, these are all, we're continuing to assess. You're doing it. You might not think you are, but you are doing it. So the vision, the ability to hear, the ability to understand, all M questions. Pain, the frequency of their pain, their dyspnea, their cognitive piece, their confusion or whether they're anxious, and their ambulation and locomotion, all at this point in time. Again, the therapies that the person receives at home. I put this in because a lot of times this question is not answered correctly. It may be listed on the referral, but it may not be, and the question should be asked. And there are some patients who were going to outpatient therapy and had an event or are still going to outpatient therapy. They're taken there. It is a taxing effort to leave the house. But outpatient therapy, the patient receives at-home therapies. This question only relates to therapies received in the home. So if the person is getting in an outpatient therapy in the physician's office, you would answer it correctly that it's not being provided at home, but it also will make you think about we need to change perhaps this type of the plan of care for the time being. Maybe they can't go to outpatient therapy, but we can bring in home care therapy if the person needs it at this point in time. So again, it's a care planning item. It could be self-care management. How will they do once we leave the home? And again, the educational portion of this. Management of oral medications. When we talk about medications with the patient, we assess their abilities to take their medication safely. Do they know what it's for? All of this is being done as we're having them sit there and read their meds to us. Is it the correct dosage and times? Many times I have been out on visits. I ask people to bring me their meds, and out comes a shoebox that has years of medications. I didn't finish this, or the doctor changed the dosage here, so I have 5 different dosages of the same pill. And I try and explain to the patient that, you know, medications are made to either be taken to the end or disposed of when you're no longer taking them. And I have to teach people how to dispose of medications, so it's another teaching item. And so this is all can be seen just from doing this particular piece of the observation and the measurements. Again, people may not have all of their medications in the home. Again, so you can't assess the medication piece, the oral medication, because the correct answer by the Oasis Convention is unable to because they don't have them. But again, this is something on the care planning side. You may need to coordinate them being able to get their medications. This happens quite often if we go the day after they've been discharged or even the day of discharge from the hospital and someone has not picked up their prescriptions for them that they were taking in the hospital. And also the management of oral medications excludes all injectables and IV medications. And very important, this question, the intent is that refers to the ability of the patient, not compliance or non-compliance or willingness or non-willingness to take it. It refers to the ability to go get the medication, open the medication bottle, put the correct dosage in their hands at the time, and then get water or whatever they use to swallow the medication and put it in their mouth and swallow it. So it's the ability of the person, not the compliance or the willingness to do it. We go now to the injectable medications, because if you've done a medication review, a person may have injectable medications such as insulin. Can they pre-fill? Can they give it to themselves on a daily basis, whether it be morning or night? Do they know how to pull up, or hopefully they will have a pen, which is much easier for people to use? And do they understand sliding scale on the insulin if they are a patient on sliding scale? And how do they get to the number on the sliding scale? What makes them take 2 or 4 or 10 units, which is, of course goes into the blood glucose monitoring? Can they do it safely? Do they know what the medication is for? Again, this is just something that you would interact with them, and you'll do it while you're doing the medication review. Again, if some or all of the medications are not in the home, it cannot assess this, and the correct answer by Oasis convention is unable. So again, if the medication is not indicated during the visit, now you may be going in for insulin administration, but you're in the morning and the insulin administration is not, or maybe you go in the afternoon and the person only takes AM insulin. You want to go through a demonstration with the patient and or the caregiver who is going to be doing that task, doing it on a demonstration to simulate the steps so that you get an understanding of their comprehension and abilities to do this. Again, part of the planning and part of the education. By doing this, you can do a gap analysis and see where there's gaps in the ability. They want to do it, but either they can't because they don't understand the steps, they don't have the dexterity, or they don't have, they need more education in how to do it before they can do it safely. So again, we talk a little bit about types and sources of assistance. This is very important in the variable data that Medicare collects. We want to see the caregiver abilities and the willingness to provide assistance. Both are very important because the caregiver could be able and not willing, or they could be not able and very willing to do it. So we have to get those variables very clear. And so it's providing assistance for medication administration, all those 3 questions, and again the assistance of the caregiver for any management of equipment that your patient may have. Is the person independent with medications and equipment? Is any assistance required? Is a caregiver present? And what is the caregiver's ability? Again, if the medication is not indicated, or again, if the management of the equipment, if the person is on oxygen, I would have them and they're not using it, I would have them simulate how they go about putting the oxygen on, putting the mask or the cannula on, and adjusting it, and making sure that, and they understand what it is for and when they would use it. So again, this goes towards the educational care plan. Now you go to number 5 of number 6, and that's the patient walks to the bathroom now. You've gotten through all your medication review, and you've answered all of those Oasis questions by virtue of that medication review. So you ask your patient to show you their bathroom, and again, I just have them do certain things in the bathroom. I have them sit on the toilet and then stand up. In a lot of old apartment buildings, I am from New York, and a lot of old apartment buildings, the sink is not on any kind of a pedestal, but it is built into the wall. And sometimes older people have lived in the same apartment for even 30 or 40 or 50 years. And for the last 12 years, they have gotten up off the bathroom. Usually the sink is next to the toilet, and they've gotten off by pushing off on the sink. And what I do, I have them do that to see how they get up, but if they push off from the sink, I also test the sink and to see if it is loose off the wall. And I would say in 50% of the cases, that happens to be the case when I do that. So we have to be very careful in terms of the safety of the person to see these things in the environment. Again, we're doing an environmental assessment. Is the bathroom clean? Is the bathroom really dirty? So is the person, sometimes I would see urine on the floor or feces on the floor. I would say, I would then ask the person, are you able to get to the bathroom in time? If their ambulation is compromised, sometimes they do not make it in time. So just from doing this, sitting on the toilet, return to the standing position, I've assessed the person's ability to get up and down, transfer safely. I've assessed the environment to make sure if the sink is not a pedestal, that it is strongly attached. And I also would look for pain on this assessment to see how the person gets up, and if they scrunch in pain because movement of their hips is painful or their shoulders. I also can see that if they use an assistive device to get up off the toilet, and perhaps I might need to know that I need to order some bathroom equipment for them. to make their lives easier and safer. I do ask the patient in the bathroom to step in and out of the shower and/or tub. I want to see the ability to lift a leg over a tub. I like it better if it's a shower. It's probably much easier to do. But again, I evaluate for equipment in that bathroom and to see what they might need. So I'm going to assess if they have any equipment. Many apartments now do have safety bars, grab rails, etc., but they may need more. And depending on their diagnosis that brings them to home care, they may need assistive toilet devices or a raised toilet seat. So we want to assess the presence of what is there already and what might be needed. Again, here we are. We're still assessing all of these things now, the ability to hear, understand us, how they talk with us, can they express language. We're doing a pain assessment and whether the pain is frequent or not. We're doing a dyspnea evaluation. We're looking at urinary incontinence and when it occurs. We're looking at bowel incontinence. We're assessing still if they're confused or anxious, and we're assessing their ambulation and locomotion. Now we're going to some of the ADLs. Again, the safe ability of the person to do the task. So we want to see in grooming, can they access the tools that they need to groom themselves, and can they perform the tasks? So that's washing their face and hands, their hair care, shaving if necessary, or makeup, teeth or denture care, fingernail care. All of that is grooming. Can they access all of the tools that they need to do this? And then you can actually watch them do a demonstration of how they would wash their face. Can they shave themselves? Do they get shaved? Do they go to a barber even once a week or once every 2 weeks for a shave? So it requires interaction and observation, both the patient and if there is a caregiver there, the caregiver also. If we go to bathing, current ability to wash the entire body safely. It excludes the grooming piece. So can they reach all areas of their body to wash themselves? And it could be with adaptive equipment. Can they get in and out of the tub safely? Again, interactions and observation. Most elderly people, I believe, really need something to assist them with the safety issue in getting in and out of a tub. And they may have cognitive issues which then necessitate supervision during the bathing process, to have somebody there to supervise them. So again, these are items that you can answer just by observing them in the bathroom. Toilet transferring, the current ability to get to and from the toilet, and then, or the bedside commode if they have one, and safely, and then transferring on or off the toilet or commode. So again, put in the bathroom, have them, as I said, get up and off. Now some people, when they go to get off of the toilet, they rock back and forth to give themselves the leverage, especially on a lower toilet rather than the new chair height toilets. So you have to really look at safety with that. Because again, some people rock so much that going forward, they can rock themselves right off of the toilet and onto the floor. So again, you have to observe them safely doing the task. And that they can do the task, but then also safely.